Okay then. Good morning. My name is Anita Day. My pronouns are she, her, and I'm chair of Worcester Acute Hospitals NHS Trust. Today is Thursday, the 9th of March, and I'm pleased to welcome you to our meeting of the Trust Board in public. My welcome goes to my fellow colleagues from the board, our guests, and indeed anyone of our wider colleagues or the public who may be joining us via YouTube. Thank you very much for joining us. Those of you, my colleagues will know that it's my custom to normally start our boards with a reference to our strategic triangle or certain aspects of it. And I'd like to pick up today on the bit that's sort of is literally central to the pyramid, that of our forward signature behaviours. We know them well. No delays every day, do what we say we will do, listen, learn, lead, work together, celebrate together. Now, as everyone knows, the last few months have been and continue to be extremely challenging for those in the acute sector nationally. And at times like this, when we are facing pressures that are beyond our control, it's really hard for our colleagues and for us to always be comfortable that they're able to deliver on those behaviour promises and give our patients the care that we know they need and deserve. We do our best, but it isn't always easy. Having said that, I do think that despite those challenges that we are facing, I think it's important for us not to forget those signature behaviours and perhaps to use those as a lens as we start to think about what we are delivering for our patients today and what we can do to make it better. And this is very much a case in point as we come to our patient story this morning. And I would urge colleagues on the board to as we reflect on the story that we're about to hear, that we think perhaps of those signature behaviours and think not only about what we can or can't do in the moment, but almost as importantly, what actions can we take after the event to try and make sure that we can minimise the chances of us delivering care that we're not happy with. I'm going to hand over to Jackie Edwards, our chief nurse, in just a moment, but I'd like to welcome Mr. Mark Chivers, who's here to tell us about the experience of his father in our hospitals. But over to you, Jackie. Thank you.
Thank you very much, Chair, and good morning to everyone, and welcome to Mr. Chivers, and thank you very much. Before we listen to Mr. Chivers' story of his father's care through our hospital, we've all had quite a busy morning, haven't we? We're all here actually having dealt with childcare for many of us in Worcestershire, and I'm sure throughout the country, the snow this morning. But what I'd ask you to do is just take a minute to clear your heads of all of that, because I think the importance of listening with fascination to this story in setting the scene for us for the rest of the agenda items is my request. I'm not going to say any more because I think the story will tell itself. And then just one key bit I would request is, what is the learning for us from listening to the story? So thank you very much, and over to Mr. Chivers.
Jackie, thank you, and good morning all. Very well, I was going to say very warm, very cold hello from Nottingham, where it is snowing quite hard at the moment. Anita mentioned it up front, so I know Anita, and I am a non-exec in Nottingham University Hospitals, and this has come out of an experience I had in one of those time periods where your trust was under very great pressure, at the same as a lot of trusts, including my trust up in Nottingham at the end of last year, beginning of this year. So I'm sort of telling the story on behalf of my 80-year-old father, who was admitted on 5 a.m. on the 30th of December last year into the Alex. And I'll come on and talk about that in a bit more detail. And I'm used to listening to patient stories. It's very, very different giving a patient story rather than listening to one. And what I've tried to do is sort of be fairly dispassionate and actually sort of take the themes out of what I think the themes would be that I would have listened to, and I won't troll through Anna's brilliant write-up of my diatribe to her. So I want to talk to you about 5 themes coming out of it. The first is A&E and the experience in A&E on the 30th of December. So Dad, just a bit of context, my father's 80. 4 or 5 years ago he had a tracheostomy in Birmingham after a laryngectomy, and his communication is pretty good. On the back of that, he copes well with the throat piece if it's all clean, and he's going increasingly deaf. So we'll come on to communication in a minute, but just a bit about that. So he was admitted. An ambulance was called after a couple of falls in the night, and he was admitted to the Alex about 5 a.m., 6 a.m. on the 30th of December, and spent 14 hours on a trolley in a corridor outside A&E. My stepbrother, who lives much more locally, was with him from midday, and I arrived down from Nottingham at about 7 at night, where he'd sort of already been there for 12 hours. And having said all that, it's an overwhelmingly positive story and experience, because notwithstanding there were ambulances queuing outside, notwithstanding the pressure that was tangible on A&E, it was being run with very good grace, with very great calmness, and there was a really there was no sense of panic or anything else in A&E. So we just sort of bided our time, and we got to the front of the queue, or what we perceived to be the front of the queue, next to the nurse's desk in the corridor. And I caught it just right, so I asked a senior nurse just before her shift change about whether anything could be done for Dad, because he'd been on the trolley for so long, and that triggered the creation of a bed was brought down from the hospital or brought across from one of the wards, and he was sort of housed for the night in a cubicle. The highlight, or the comedy moment, there's always a comedy moment in all of this, was sort of about 14 hours into it. Dad said to me, communication not great, but Dad said to me, I should have gone private, shouldn't I? And I sort of said to him at that point that wasn't really an option, but he was calm, he was good, and Ngozi, the nurse who came on shift, settled him down for the night really well. So that's the first message I wanted to give you, that A&E was, notwithstanding very great pressure, was dealt with calmness and measured professionality. The next theme I wanted to go on to was sort of moves. So I turned up back at the hospital 9 o'clock the following morning, 8:30 the following morning, whatever, and he was no longer in A&E, and he'd been moved to AMU. So sometime in the night a bed had been found. The cubicle was only provided on the basis that there weren't going to be any beds in the hospital that night, so that was, but I assume that the pressure on the cubicles in A&E became more intense, and he was moved on to AMU. By the time I arrived, the healthcare assistant in AMU had just built a rapport with Dad and was managing her 6-bed ward just absolutely brilliantly. And she was bantering with all of the people in the beds, and it was just Dad was content. He was feeling well cared for, and the lady was just outstanding. So full credit to all of her. We then had a series of visits from consultants, from foundation doctors, and so on. And what transpired was the reasons for the falls and the reasons for admittance. The perception was that he needed a pacemaker fitted. So we started to talk to cardiology people, and by this time, his hearing aids were running out, and I needed to go to his flat to get his hearing aids charger, because communication is so important for him, being able to be heard, and indeed the difficulty with not having cleaned his throat and so on for a tracheostomy. So communication is starting to be a bit difficult. So the perception was that cardiology beds were as rare as hen's teeth, and there wouldn't be any move while I was away. Anyway, I went about an hour and a half round trip to go and get his chargers for his hearing aids and a few other bits and pieces. And by the time I moved back, I got back, he'd been moved on to cardiology, so that transfer had happened. And that was the cause of concern. Dad was muddled. I told him I'd be back long before he was moved to cardiology, and so on. So that was a difficult bit, and I know you've got to do what you've got to do when a bed becomes available, and so on. But that was difficult, and a bit of miscommunication, which we'll come on to. And then subsequently, I only found out by accident, really, because my brother-in-law turned up to the hospital to see my father later in the stay, that he was then going to be moved to Worcester. So again, your movement around the hospital of patients, and I know you know this, it causes concern, it causes potential discomfort, confusion for more elderly patients, and it needs to be communicated to the families. So we sort of only found out a little bit later that he was going to move to Worcester. I then rang Worcester in the morning after his move, in the middle of the night, and the ward didn't even know whether he was on that ward or not at that point, and they had to go and check. So that sort of takes me on to theme 3, which is communication. So we're a bit of probably not atypical in terms of your patients' families, but I live in Nottingham. My 2 sisters, one lives in Preston, one lives in Penrith, but we have got a stepbrother who lives in Ulster, so not far away, and we found it quite difficult to find out what was going on with Dad, and sort of who was talking to the hospitals, what was happening. We weren't getting notifications. We found out, as I say, about the transport move to Worcester in a relatively ad hoc fashion, and then it was just all going to happen at some point in the night. There was then a number of other points around communication, and about both of my sisters at various parts of my father's stay came down to help with discharge and help get him back into the flat. The first time was inadvertent. It was too early because he fell, but we'll come on to that. Just a real point around communication, and a sub point with Dad in particular, with the trachea and the hearing aids. So I moved to Worcester, the hearing aids and the hearing aid charger, which I'd gone to the flat to get, got lost. So when he got to Worcester, he didn't have any ability to charge the hearing aids that he was wearing. And anyway, it transpired in the end that it had been left at the Alex. My stepbrother went in and got them, and then delivered it across to Worcester. So all of that was fine in the end. Dad had been, so theme 4 falls. Dad had been admitted for falling, and the pacemaker was introduced, so he had that procedure, all of which was brilliant, absolutely faultless. My sister came down from Penrith because it was proposed that he was going to be discharged on the 5th, so she came down, and anyway, he fell during the night, and that of course then triggered a series of additional tests and scans and so on to see whether he'd either dislodged the pacemaker or had damaged himself in any way. Luckily he hadn't, so he was then going to be discharged on, I think, on the 5th. So my sister was there. She was with him all day. Dad was already dressed. He was so excited about going home, and we were waiting for transport. Again, a common issue, I'm sure, waiting for transport to be transferred home. And Louise, my sister, had basically had enough of Dad or being there and sort of badgering about when are we going. So she went down to Costa in Worcester to get herself a coffee, and anyway, when she got back, she found that Dad was on the bed with a bleeding head because he'd fallen again, and was sort of literally bleeding. And the only instance of sort of poor communication, or what we perceived to be poor care, was she went out to the desk on Aconbury and said, my father's got a bleeding head, he's lying bleeding onto his pillow, and she was told, yes, we know. So that was the only sort of instance of sort of poor care, on sort of different conflicting priorities. So anyway, came out on the 7th. So my other sister had by this time come down from Preston to help with discharged at 5:30. So again, the issue about transport. And my last theme for you is something that I've heard about very often as a non-exec, listening to stories like this. But the first time I'd really experienced it, and I wanted to underline it, is just how significant those 9 or 10 days in hospital were for the deterioration of my father. So he went in, having been with us for Christmas, having been with my other sister for Christmas, so 10 days away from home, and sort of mobile, relatively happy, content, or whatever. And he came out after those 9 days in hospital with very, very significant mental deterioration and very significant physical deterioration. He came out basically immobile. And it has taken him the time since to build up some of that strength back. And I know that's no fault of the hospital. It's something that all hospitals observe, but I wanted to underline it to all of you, just for you to realise how significant it was when you see it in one of the family and you see it for yourself. At which point I will shut up. You're very welcome to ask me any questions. I may have to come back to you if I can't answer them, but hopefully that's useful.
Mark, thank you very much. That was very useful and really clear, and thank you for structuring it in such an effective way. There are some advantages with dealing with people that know how this stuff works, I think. So no, that was great. Any questions or comments, please? Simon.
Thanks very much, Mark, for sharing that. So for me, the takeaways from there would be obviously the communication side of things. And as colleagues here on the gallery will know, I've been down a similar route quite recently with 2 elderly relatives, and that was a bit of an issue as well. The deconditioning within hospital for older people is just something that I don't think any of us have got a handle on anywhere in the NHS. It is a very difficult subject to deal with, but I'd perhaps welcome, I don't know, your comments or Jackie's comments or others on the gallery on how you might address that aspect of it. But it's much appreciated for you to take the time and explain that journey, because it is helpful to us to see and hear that first-hand experience. But I guess for me, the learning would be how can we communicate that better, and then maybe are there things we can do ourselves which could address some of the issues of why people do actually deteriorate when they're in a hospital rather than come out better is perhaps not the right word, but in a stronger position than when they went in.
Thank you, Simon. Matthew, do you want to come in on that, or are you going to make another point?
Yes, thanks, Anita, and thanks, Mark. And please accept my apologies for the perhaps the episode of poor care and clearly the lack of communication that you as a family experienced during your dad's stay with us. And as you say, we are conscious of the risks around hospital-acquired functional decline, which is as you probably know, the technical term for what you're describing there in terms of deconditioning. And over the last year, we have seen our hospital length of stay at both the Alex and the Worcester site go up. And that can only increase the risk of functional decline for what often is predominantly a frail elderly population that we're seeing where length of stay is rising. We're actually halfway through an independent review of our ward-based treatment plans in order to try and understand a bit better what are the factors behind that increased length of stay because of the risks associated with functional decline. But we also know that multiple ward moves increase length of stay as well. And I think that's something that we also need to be mindful from your dad's experience, that I suspect whilst treating the underlying cause for his falls, the risk associated with increasing length of stay and therefore functional decline is something that creates a tension, I think, in hospital care at the moment. But thank you for sharing your experience, and please pass on my apologies to your siblings as well in relation to the things that we didn't get right.
Thank you, Matthew. Jackie.
Yeah, thank you very much, and thank you, Mr. Chivers. I think, many of us as professionals, we talk about functional decline. We talk about it a lot. It's a real key quality indicator for us, and has been for a number of years. And I have to say, we've still got a long way to go to actually get this right. There are lots of things that we are looking to do, and it really is a very holistic approach to it that we do need to take, from thinking about a healing environment, and wards often are not the most healing environments in respect of light, noise, where the beds are, how easy it is to get to and from the toilet to make sure you're maintaining your independence. Have people got clothes that their loved ones can bring in, that we can then dress them in, rather than you're in the the traditional hospital nightwear. All of those things that we are driving through, but the importance of it, I think, is the key message that your story really illustrates, because we do all of those things, but its impact actually on how someone feels safe, how someone sees themselves, really was the bit for me that came through in your story. And actually, we have the privilege of looking after people for quite a short period of time, but their carers and their loved ones are the people who are actually looking after people outside of the hospital. So I think some of the pieces of work that we are doing across the system is how can we, with the involvement of Carers Association, for example, really start to address this across the pathway. So not just from the hospital point of view, but actually pre and post coming into hospital. So just to give you a few illustrations there, but once again, thank you very much.
Thank you, Jackie.
Sorry, Anita, just forgive me. So it was overwhelmingly a positive experience, I think, for my father. The falls were most unfortunate because, as Matthew and Jackie have alluded to, the falls increased the length of stay and increased that deterioration. And it's very easy sitting as a non-exec, particularly when it's not your family, to say, well, you need to stop people falling, don't you? And the trust that I saw was dealing with staff shortages and so on with very good grace and managing to the best of its ability. the stat that I was told, and I believe it, was that on 31st, the cardiology ward was being run on 2 nurses and 3 HCAs. And still, notwithstanding that's probably too few people, ideally it was still being run with very good grace, and Dawn, the healthcare assistant on the cardiology ward, dealt with Dad really well. So I think you should be very proud of the services and the care that you give. And I won't say we're dancing on the head of the pin, but you can always communicate better. Everyone can always communicate better. So it wasn't meant to be a story that was taken as being critical.
Thank you, Mark, for saying that. That's great. I had one question. I think you mentioned in your story that the move from the cubicle in ED to AMU, which happened, I think, in the middle of the night, was one that your father found particularly difficult and quite disturbing, or at least disorienting, shall I say. I mean, looking back on it now, what...
Anita, it was, forgive me, it was more the move from AMU to cardiology, just because I disappeared to get his hearing aid charges, and I told him on the basis of what I've been told that it was very unlikely that he would be moved. So there was then an additional concern, well, when Mark comes back he won't be able to find me, and so on and so on. So it was more that, and probably testament to how effective the healthcare assistant in AMU, just in the space of a morning, had built up a rapport and a relationship with my father. So
okay. Oh no, that makes more sense. No, understand. Simon.
I guess one final question, Mark, is how is Dad now?
So he is back. He's at a graded facility, so he has a flat of his own, but he's lucky enough to be able to afford to live in a nice place, and there's a care home floor and a nursing floor. And when he came out of hospital, he was in the care home floor for a couple of months to rebuild some strength and just general wellness. He's now back in his flat. We've introduced, again, lucky that he can afford it, 24/7 care. So he has someone living in the flat with him to provide care. And we've just heard that from the carer that the carer is not going to come back after his holiday because Dad's deteriorating. So that's my job for the weekend, to get to the bottom of that. So he's in a decline, but physically much stronger and more mobile than when he came out of hospital. And I'm assuming he's getting checks on the pacemaker and stuff, so I assume that has reduced the risks of falling, albeit he has sort of, I think, more slipped rather than fell since he's been back in the flat. So he's better than he was. Thank you very much, Simon.
Thank you. I don't see any other hands raised. So Mark, again, thank you so much for sharing this story. It's great to hear that so many aspects of the care were actually really good, and you've reiterated areas, of communications, of bed moves and so on, which, and as you say, a functional decline, are things that we are well aware of. But it's helpful to have it sort of brought to life in the way that you did. Pleased that your father has been improving over the last couple of months, and good luck sorting out the situation that you need to do in terms of care now. But really appreciate you taking your time to join us, and good luck with everything, and thank you.
Anita, lovely to see you, and all the best to all the trust. Have a good meeting.
Thank you very much.
Take care.
Thank you. Bye-bye. Great. Okay. Thank you. let's move on. I know we will probably need to reflect on bits of that, but let's move on for now. So going into the meeting, we have received apologies from Julie Moore, Richard Oostrom and Karen Martin. Items of any other business. I've not been notified of any. Does anyone have anything they would like to raise and add to the agenda? I don't see any hands raised. Declarations of interest. Obviously the standard ones are on the website. Does anyone have any specific declarations that they wish to make with regard to today's agenda? No? Okay, brilliant. Okay, then minutes of the previous meeting are in the pack. Can we just be comfortable? Are we happy that this is a fair record of the meeting on the 9th of February? Running through, they were, as usual, very detailed minutes. Jackie.
Thank you very much, Chair. It's just one point. Actually, under nurse staffing section, it says there's a rise in vacancies has been seen and now is at 8%. Actually, it's actually the rise is that it was of 8%. It says actually of, and it should be at. So we've not gone up by 8%. We actually are at 8%. Thank you.
Thank you for that clarification. Any other points of clarification on the minutes? I don't see any other hands. Are we happy to accept these as a true record? Thank you very much. Moving on then to action log. Rebecca.
Yes, Chair, the updates as per the log, there's nothing to escalate, and as you're aware, we're going for the review of the board development plan. Thanks.
Great. Simon.
Could I just congratulate Tina and her team, Richard Luckett, on the Worcestershire Weekly a couple of weeks ago, where we're addressing how to make the behavioural charter, I guess, more relevant to colleagues' working daily lives, and we now have a new strapline for it, which is Speak Up, Report It, Sort It. So I think that will be welcomed by colleagues who are trying to make this more real, and I know there'll be further work done on this, but that was great to see, and thank you very much.
Thank you, Simon. Well said. Right, so moving on to Chair's report. Well, I don't really, I would like to take my report as read. As you will see, I did have to do a Chair's action in respect of the managed print service contract extension. Can I have your confirmation of ratification of that? Yep, thank you very much. Then moving on to Chief Executive's report. Matthew.
Thank you, Chair. Good morning, everybody. Obviously, take the paper as read. A couple of key points just to draw out for the board to note this morning. The planning for next financial year, commencing 1st of April, is continuing at pace. I think the continuing iterations of the plan are progressing in the right direction, particularly in relation to plans to deliver on the performance target priorities for Acute Trust next year. We now have a bottom-up build plan to deliver on the 65-week zero target for the end of next financial year. The 62-day cancer standard in terms of the number set for us by NHS England has changed since the last discussion with the board, has reduced to 190, so the team under Paul's leadership is continuing to develop that plan, which is now the goalposts have changed, so we will report back on that in due course, and work is progressing on the diagnostic standard as well. I think it's worth noting that each of those, notwithstanding an increase in demand that's over what is anticipated, are largely within our gift. The one that isn't within our gift is getting to an emergency care standard of 76% for the end of March 2024, because of course the urgent emergency care 4-hour standard is a system standard as opposed to an acute trust standard, because acute trusts are unable to deliver against that without the help of partners Community Trust, social care, and the ambulance service. So work is also continuing with system partners in order to set out a plan to move from what we're likely to have seen in this financial year of around a 60% performance to a 76% performance by the end of March 2024. So more on that over the course of the next few weeks, but priorities for the leadership team and the divisional team is very much centred around developing a robust plan, both operational and financial plan, that gives us a plan that can be delivered and is realistic, as opposed to setting unrealistic expectations. Worth noting as well, the Garden Suite, again, going back, Anita, to your point about forward behaviours, we do as we say we will do. The intention was always to return the Garden Suite, which is our ambulatory chemotherapy unit, originally based at the Alex, moved to the Kidderminster site, which was our green site during the COVID pandemic incident response. And again, big thanks to all of the clinical operational estates teams and communications teams from handling the dynamic moving the service back to the Alex, and is now treating patients on Ward 1, but settling back in, which is good for patients, good for staff. Congratulations to the electronic patient record team and all the clinical teams that got involved in that. It's always great to be on the wards and seeing our staff comfortably using electronic patient record via the mobile laptops and computers, and appearing to be relatively comfortable with it. At least that's what they said to me. So that's all very good, and we're obviously well in the process of planning for the second phase of that rollout. Ambulance handover delays continue to be a national priority, continue to be a local priority for us. It's a clinical risk for any patients waiting too long, and we heard from Mark's story earlier that it can contribute to functional decline. We've been de-escalated from the national oversight, but continue to work with our regional colleagues to reduce the number of handovers delays that patients are experiencing. And then industrial action continues to be a priority. It's a major worry. You can see in the papers setting out there the industrial action next dates. The one that we're most concerned about, as you can imagine, is the 72-hour full stoppage of work, including nights on call and non-resident work by junior doctors. We are continuing to work with the British Medical Association and the HCSA to support our juniors, to support the consultants that will be stepping in to provide supportive care. But it's fair to say that the impact on patients will be huge next week, and also the impact on many of our staff that will have to get involved in cancelling and rebooking patients that we have to cancel in order to prioritise emergency care. So again, stress, I'm sure the board will support this, the need for swift resolution by government with the unions to resolve the ongoing pay dispute, because the impact on patients, staff and leaders in the NHS is untenable, and the patient safety risks next week are also untenable. And as the accountable officer, take this opportunity to stress once again swift and timely resolution to the ongoing industrial action dispute is absolutely critical. And then finally, Chair, this is Mr. Paul Brennan Esquire's final board meeting. Paul's been with us since October 2018, where he landed as Chief Operating Officer and Deputy Chief Executive, and almost immediately was cast into the throng of being Acting Chief Executive for a few months until I joined the organisation. We know and love Paul for his unique style and his massive contribution to the organisation, to really starting in earnest to fill that demand and capacity gap with the additional resources, building staff that have been put in place But let's not forget, during the COVID pandemic, Paul was our gold commander, led that with aplomb, developed and oversaw what I think is well regarded as a very positive response to the peaks of the pandemic, and also I think doing it in a way that has particularly taken forward in this organisation the clinically led, managerially supported approach that I know as a board that we fully endorse. I think the relationship with the clinical leaders and the management teams here is something that we should speak more positively about when compared to many organisations where that ethos and culture doesn't exist. We wish Paul a very happy retirement. I know he and Janine have got some plans for spending some quality time together. And I know that we'll all miss him, but wish him a long, healthy, and enjoyable retirement as he goes off into the countryside with a cigar and a nice glass of Shiraz, and puts his feet up, and his ballpoint pen is hung up for the final time. Thank you, Paul, for your personal support to me, particularly during the time when I was off having my kidney transplant, and thanks for your unerring support and focus on putting patients first. Just to note, the replacement process is a couple of weeks' time, and I'll report to the board in due course. But thank you, Paul, on behalf of the board and the executive team and the patients for everything you've done over the last nearly 4.5 years, and happy retirement. Thank you, Chair. That's my report. Happy to take any questions.
Thank you, Matthew. Colin.
Thank you, Chair. Echo the Chief Exec's comments about Paul, by the way. Absolutely well deserved. Congratulations there to him. But my query is relating to the rollout of the EPR in ED and related units. And that arises really from the NED's visit to the Alex earlier in the week, when Tony and I had the privilege of going to ED. And I have to say, before I reached the specific point, I found, and I'm sure you'd agree, Tony, an inspirational leadership there. And I'm not at all surprised, I'm not complacent, but not surprised about positive comments that Mr. Chivers made about the atmosphere there. It really is relaxed and calm, and it gives the impression of well in control, even despite the pressures that they are under. But the particular issue I would like to raise is that of the rollout of EPR, because I understand that in the emergency ED it's not out there yet, and in the unit behind AME I think there's mixed running, so there's some paper and some system-based support to staff there. So how are we going to progress that?
Right. Thanks, Colin. I'm going to go to Vicky, because I'm guessing she'd like to come in on that point.
Yeah, thank you very much, Chair. Thank you, Colin, for the feedback. So ED deployment is actually a later phase. I think from memory, Colin, it's about phase 2, so it's later on in this financial year, trying to coincide it with the move into the new UEC building here at Worcester at Wells. So that's why you've seen that difference there. They actually use a system called Patient First at this moment in time, and they also have access to the PAS. In terms of the deployment time frame, it'd perhaps be useful if we could walk NEDs and Trust Board members through that, maybe at a later date, and give more clarity in terms of the functionality as and when it comes online. And then in terms of the other issue you raised, in terms of the assessment unit behind it, because the deployment of phase 1 was certain aspects of inpatient documentation, so it was medical clerking and it was the News 2 from memory, along with other things. Actually, the full clinical documentation comes in phase 1A, which will follow very shortly. We're just in the current planning stage for that. So that's why we've got a recognised risk around that hybrid record piece. We've got some aspects on paper, some aspects on the system. And we have talked about that through our programme governance steering group in terms of how we manage that hybrid risk as we go through the deployment phases as well. But thank you very much for the feedback.
Thank you, Vicky. Simon.
I won't add to the comments about Paul because we'll have an opportunity elsewhere to do that directly. I'd just like to thank colleagues for all the work they've done to get us to the point where we've been de-escalated on handovers from national to regional. I think there's a lot of hard work gone into that. We're seeing sustainable trends now. Obviously, we're hoping they're sustainable, but of itself, I think it is worth acknowledging publicly that a lot of hard work has gone in to make this happen by a lot of hard-working staff, and I'd just like to say a big thank you.
Thank you, Simon, and absolutely agree. I don't see any other hands, so I mean, just a couple of comments. There was a lot of really good content there in Matthew's report, and completely agree. We've actually got there's some real positive things in there. It was great to see the Garden Suite go back ahead of schedule. It was great to see the EPR phase 1 be implemented as well as it has been. The ambulance de-escalation, as Simon has alluded to, and of course the comments about Paul, we would all wholeheartedly, this organisation, a lot of the progress we've made in terms of our operational performance is down to Paul and his team and colleagues, of course. But I think he has been instrumental in all of this, and he will be very much missed. Absolutely. Did just want to just pick up on two things. Matthew mentioned the industrial action, and as he said, this is a period of real. It's a really difficult time. It's a difficult time for us. It's also a difficult time for our staff, and we've talked about this before, and we know that for many of our staff, that they're faced with almost impossible decisions to take about what to do for the best. And I think, as we've said before, whatever people decide to do, we need to be respectful of their right to do that. We have to be respectful of the fact that at the end of this, when this is all over, we will come back together as a team and we will work together, and we need to do that. But I would also echo Matthew's call that we need that support from the centre. The disruption, the risks to patient safety, the real risk of patient harm from any of this industrial action, be it from ambulances, from nurses, from physiotherapists, from anyone here, and of course the junior doctors, and the period of uncertainty. We are literally having to ring patients up and cancel elective appointments, and that's all deeply disturbing for our staff, and it's obviously deeply disturbing for our patients. We really do need government support to help resolve this current climate, because what we all want to do is to get back to giving the best possible care to our patients, and at the moment, no sooner do we make a plan to do something and it all goes up in a puff of smoke for reasons that are completely beyond our control. So absolutely echo Matthew's comments and plea that we really do need some help here for us to move on and give the best possible care we can to the people of Worcestershire. If there are no other comments on that, thank you, Matthew, for your report, and I would like to move on to the next thing, which is the communications and engagement update. Richard.
Thank you, Chair. I think we've already reflected through the introductory items, and particularly through the patient story, the very real challenges that we face as an organisation, but also I think our pride at the staff in teams across the trust who are working so hard to put our patients first. So while I will take the report as read, and at the risk of taking on the role of what your predecessor was pleased to call our chief evangelical officer, the report just contains just a few highlights of stories around colleagues putting patients first, around the significant investment that we're making in new services and new facilities, not just as an end in themselves, but to further improve the quality and safety of the care that we can provide for our patients, and our ongoing improvement journey and the development of strategies and ways of working that will make our hospitals even better places to work, and by doing that make them even better places in which to be cared for. And I think Colin's already referred to the Gemba walk that a number of non-executive colleagues did on Tuesday. Also on Tuesday, with Joe and Christine and Matthew, I was lucky enough to be able to spend the day at our third Leading Forward conference, which brought together colleagues from across the organisation, more than 100 of them, consultants, matrons, senior managers, members of our improvement team, to talk about our forward improvement system and how it's increasingly being applied in practical ways by teams across the Trust to deliver real improvements in the way we manage the organisation. And I think what was striking was one of the real changes we've seen in the Trust, certainly since I came back a little over 5 years ago, is a growing confidence on the part of clinical and corporate teams in telling their own good news stories. And I'm sure colleagues see that for themselves firsthand when they walk around the organisation. So notwithstanding very real challenges we face, I find myself and the comms team find themselves now in a place where actually people are bringing good news stories to us rather than us having to pursue them literally in some cases down corridors to extract it. And oftentimes we find ourselves with more good news than we can effectively manage, which is a challenge, but it's a very welcome challenge to have. And I think supporting that narrative, building that coherent story is a really important role for me and for the comms team, also for board colleagues. But most importantly, and I've used this phrase in the past, we have a comms team of 6, but we have 6,500 communications officers in our hospitals 24 hours a day, 7 days a week, 365 days a year. And it's great to be able to listen to them telling the stories of the progress that they have made and are making, and their commitment to the aims and objectives of our strategic pyramid, and increasingly demonstrating that mindset of better never stop, so that we can hear sometimes challenging patient stories, welcome that feedback, and know that our teams will take it on board and continue moving forward. I think I'll leave it there, Chair, but I'm more than happy to answer any questions that board colleagues may have.
Sorry, thank you, Richard. Simon.
Just to thank you, Richard, to you and the team for the great job you did on promoting the Rainbow Badge. I know that's been very well received and it's had a good profile. And I'd encourage everybody on the gallery here, board members, to do the Rainbow Badge training themselves. It's well worth the effort. I think there's only 2 or 3 of us who've committed to it so far, but if you can do, because it's well worth doing. But well done to the comms team. It's had a really good profile, and I think it's got a good launch going for us.
Thank you, Simon. I will feed that back to my excellent team. At the risk of sounding like an Oscar winner, it's a great example of teamwork where we've got a very engaged network. We've got people like Luke and Beck who are prepared to bring their ideas forward and crucially deliver what we can provide for them. So it's a great example of many of the things I was just saying, but thank you.
Absolutely right, and completely agree. And I have done that training. It is excellent, and I really would encourage people to do the training or sign up for it if they haven't done so. I think it's helpful, and I think yes, it's about LGBTQ specifically, but actually in terms of a mindset that can impact any of our colleagues with any types of diversity. I think it's a good thing to do. Matthew.
Yeah, thanks, Chair. Just Simon, just to note, the fact that there isn't necessarily a lot of people signed up at the moment is not an indication of commitment. We're in the process of trying to change the way in which training is delivered to fit into some of our fixed meetings, and that's going to be probably the model that is going to get certainly an executive team done more quickly. So that's the approach. I just thought it'd be helpful to note that. Thanks.
Yes. And in terms of the general report, I don't see any other hands. Thank you, Richard. I mean, I do actually think our communications engagement team are really firing on all cylinders at the moment. It's great to see the amount of stuff out there. Even I think yesterday a poorly octopus with a bandage around its tentacle. But these are the kinds of things that actually just keep these positive stories, these warm stories out there. And I think it's a great example of using all these little things to just kind of keep talking about us and keep talking about the care that we give to patients. So absolutely echo previous comments. I think things are, thank you to the whole team for the work you're doing in this area. It feels like we've got more to talk about, and we're talking about it more effectively and efficiently than we were having in the past. So good job. Thank you.
Thank you, Chair. And I hope board colleagues will take that goodwill with them into the April meeting, when we try for the first time to live stream a meeting in person.
We're all dying to. You can't wait, Richard. Although I would like to see the tech in practice, but just to give me a little bit of comfort before we actually go live. But
I couldn't agree more, Chair.
No, lovely, good job. Thanks to the whole team. Thank you for the update. Right, moving on then to the integrated performance report, and I'm handing over to Vicky.
Thanks very much, Chair. This is the integrated performance report for month 10. First of all, I may start with an apology, Chair. You will notice that there are no patient flow indicators included within the SPC chart or the narrative within the appendices. Apologies for that, though we do reference it slightly within the executive summary, and I'm sure Paul will explore in detail more of those issues. So apologies from myself on that particular occasion. It will be addressed for next time. So this is our integrated performance report for month 10, which was January. It was not seen in full at subcommittees of the board due to the business cycle relating to February, and that being a short month. It has an overall assurance level of 4, which remains unchanged throughout this financial year. And as per other months, we've identified issues around operational performance across both urgent and emergency care, elective recovery, including cancer. Though you will note from the successes page in your pack that actually we've started to see some real green shoots around the cancer performance times. Got the quality and safety section in there, which was given as a verbal update to Quality Governance Committee because that narrative was not available in the overarching report at that time. We've also got some workforce information in there, and I'll leave Neil to talk about the finance piece. And I'll pass to Paul, if I may, Chair. Thank you very much.
Thank you.
Thanks, Vicky. Thanks, Chair. I mean, I think obviously this is the month 10 report, and I'm sure board members would be more interested in where we are, given that we're only 22 days from the end of the year. So I mean, just in relation to the report as presented, I mean, I think there's a lesson for us here. If colleagues look at the table on page 2 of the report under elective recovery, you'll see that we have kind of adjusted that recently, so it shows both the submitted plan, which as I'm finishing I can call it now what I normally call it, which is the imposed plan, but it also shows the bottom-up plan, which was the work done by all of the clinical divisions about what was achievable. And if you look for new outpatients, you'll see that the year-to-date position, the bottom-up plan was actually about 138,000, and at the moment we stand at 158,000. And for day cases, the plan was 64, and we stand at 67. I acknowledge the plan for inpatients was 5,700, and we're at 5,000, but inpatients and day cases combined are above the plan. So I think it is important that when we are particularly going into our final submissions for 23-24, that we're cognizant of the work done by the divisional teams and recognise that they do know their business, and it's important that their views about what is achievable, whilst we must challenge as a board and an executive to get the best for our patients, we do need to be cognizant of what they feel is achievable. I think just to make that point, I think I'd just pick up then on a couple of areas. So in relation to elective care, we are still saying that our risk of the number of 78-week patients at the end of March is 412. However, if I look at the position today, based on our trajectory for that number to actually be nil, then by close of play tomorrow, we should be down to 917. Our position this morning is 814, so we're probably going to end this week with 3 weeks to go, about 120 to 140 below the trajectory, and that is the trajectory to get us to naught. So I will review the position with colleagues over the next couple of days to see whether we feel now there's a bit more confidence in going below that 412. I would say of the 814 patients still to manage, 460 of those are already dated, so that gives a bit more confidence to bettering the 412, but I have to say I still don't think there's any way we can get down to zero because of the number of new outpatients that we've seen, and we are now down from being a couple of thousand at the end of January. The number of new outpatients to still be seen is 27, but we have experienced a higher conversion rate than we'd anticipated to diagnostic and then onto inpatient or day case care. But we'll continue to work through. Our aim will still be to get to naught and certainly to better the 412. But as I say, as at midnight, we're 103 better than plan, and that plan is still got another 24 hours to go. In terms of cancer, again, we're continuing to see improvements. We've now seen a reduction week on week since the beginning of January. You'll recall that our trajectory for the year end for patients waiting over 62 days is 328. The position at the beginning of this week against a trajectory of 436 is actually 302. So not only are we ahead of where we said we would be, we are now below the year-end trajectory. I have to say, I think I feel quite confident in saying we will be better than the year-end trajectory. I don't feel confident in saying by how much until we get through next week, as we have a significant number of cancer patients who are listed on Monday, Tuesday and Wednesday, and at the moment I can't give confidence that we'll be able to proceed with all of those operations given the junior doctor strike, which I'm sure we'll come back to later, but I'm confident we will come in below the 328, and I think we might end up with a number of 2, but it's just the worry about next week's industrial action. So that's the position on elective. If there are any questions before I just go on to emergency.
I can't see any hands raised, but can I just, on behalf of the board, acknowledge that that's some really good progress there. So thank you to everyone involved in doing that. That's been an awful lot of hard work, and to be coming in ahead of trajectory at this stage, or likely to, I think is really a far better place to be than I think many of us feared we would be at this stage. So this is excellent. So very well done to the teams for their hard work.
Thank you. Then in terms of emergency care, we still, we are still struggling at times with flow. I think where Matthew and myself have kind of agreed is that when we're tipping 400 patients in the 2 EDs and 130 ambulance conveyances, that does seem to be an upper limit of our ability to manage the situation. And we do see when that happens, our EDs are congested, and we do have challenges with ambulance handovers. When we are containing it below those levels, that's where we're seeing the improved performance. And in terms of the point referenced in Matthew's Chief Exec report, just to give an update, if we look back over the last 3 weeks, because it's too early to say for this week, as I said in the report, at times our ambulance handover time lost was over 1,400, and for the last 3 weeks that's gone down to 350, 326, and down to 274 last week. So I do think that the improvement is sustained. It's just the challenge is the answer should be naught. But I think it does demonstrate that we're down to about a third of the handover delays that we were compared to at our peak. So I think we are demonstrating that is sustainable. The issue is how do we get the next step up to get it down even further. And I think the big challenge there is the quantum and timing of discharges during the day, and our ability to recruit more colleagues, particularly into the GIM rota undertake and support to AEC. But I do feel that both of our new units, our surgical assessment unit is working fantastically well and pulling patients through, and that is appreciated by colleagues in ED. Equally, the medical assessment unit is seeing significantly more patients than it did when it was in its old location in Mulberry. So I think those 2 units are key to our future success, alongside the need to hit our weekly target of 740 discharges a week, with at least 30% of them before midday, and that we're averaging now about, of that 740 target, we're averaging about 89%. So we need that extra 11%, but we also need them brought forward.
Thank you, Paul. Any questions or comments? Simon?
Thanks, Paul. And some of us had the opportunity to discuss this with colleagues from the Health and Care Trust earlier this week around discharges and how that's going to develop into the future. And obviously there's no easy solution there, and there's some things in our control. But what about the front door? I know Vicky's acknowledged that we didn't have the flow charts that we had previously in terms of numbers that we think might not need to have come to us at all in the first place, which helps at least that part of the process. I know it's not directly related to discharges, but how about the front door in terms of getting our ambulance handovers down below those numbers that you said, the 300s, the 200s to zero?
So the numbers I'm quoting are the minutes lost due to delayed handover, not the number of handover delays.
Sorry, no, I didn't express that well, but yeah, the lost time.
Yeah, so I've had this discussion with the chair. I'm still struggling, and I'm trying to get it done before I leave, with demonstrating the extent to which we have attendances in ED that are inappropriate, which is then causing crowding, which has a direct link to ambulance handover times. We think, at times we've seen the analysis that Vicky's team, etc., have done for me could indicate that any point in time around 16% of patients who are presenting to our EDs could be managed in an alternative setting. But that is on the basis of doing an analysis of the presenting condition. It's possible that the patient presenting could have had additional complications that analysis can't pick up. So it is more of an art than a science on that one. And equally, I think that the next step is a broader system-wide discussion and agreement on how we want to manage and the services we want to provide, so that only emergency patients present to ED, because you have this spectrum of minor illness, minor injury, majory, and then serious and resuscitation. And within our system to date, there has been a kind of reluctance to develop urgent treatment centres because of a belief that could attract more patients. But I do think time is now right to reassess that view, to see what is the best configuration of services and provision of services to manage those people who are presenting predominantly to R2EDs, but also to the minor injuries units either at Kidderminster or the 3 provided by colleagues in the Health and Care Trust. And I do think we should come to the table with an open mind to see what we think is the best way to manage that cohort of patients. Because 16% is quite a lot in the context of, around about 400 presentations a day.
Yeah, thanks, Paul. And I think we all know, I mean, certainly in recent weeks, I've been having those discussions. I did a shift with the ambulance service a couple of weeks ago, and that was very revealing in terms of some of the behaviours that may be happening that are perhaps not helping our front door, and ditto conversations we had with the Health and Care Trust. There were some very, very interesting ideas that came out of that as well, and I think this is absolutely, as a system, this is something that we need to be talking about as a matter of urgency, because this is affecting everyone. It's affecting the ambulance service, it's affecting us, it's affecting community services, and it's in all our interests to kind of get a more sustainable model here. So yeah, thanks. Jo, you wanted to come in?
Yeah, just to support what Paul and Simon and yourself are saying. So we've had a first system discussion about this just this week. I think there is a willingness for everybody to come around the table and think about urgent care in the round in a different way. So that work is progressing and is one of our priorities for next year.
Thank you, Jo. Don't see any other hands raised at the moment. Are you carrying on, Paul, or are we handing over to somebody else?
No, I'm handing back to Vicky.
Okay. Oh, is it Jackie for quality and safety? Is it Jack? Vicky's nodding. Jackie, over to you.
Thank you. Well, we're a bit of a double act, myself and Christine, with regards to quality and safety. So thank you for that. You will note from the report that our data for quality and safety is December data. And what I'd like to do with Christine is obviously, whilst we appreciate this is December data, to provide you with some of the assurances of actually more up-to-date oversight of some of these very important metrics. I think overall I'd like to begin with, and as we've heard from the meeting, actually the pressure on the hospital with regards to capacity and acuity. Actually, we are through our winter months here. That the review, very importantly, of our patient experience is demonstrating a positive experience overall. And as you can see from our data of December, actually for inpatients achieving our target and have consistently done so, of 97.7%. And I can give you some assurance that has continued through January and through February. The one area I would like to just draw focus to is a very key priority for us, which is our infection prevention and control. And I've reported to board last month with regards to this. We continue to be challenged with outbreaks. As I reported last month, we were seeing, particularly through January into February, norovirus being a real particular challenge, where we saw a decline in our numbers of patients with COVID and flu, thankfully. As of latter part of February and obviously into March, we are seeing our COVID numbers increasing slightly, as nationally we are seeing a wave of that within the community, and we are being impacted with regards to that, which obviously is important, because that does make sure we are following our strict infection prevention and control measures, has an impact on the ability for patient flow. We had our visit in October, as I've reported from NHSE. We're in very close contact with our colleagues with regards to the action plan, which I've reported through to QGC in delivering, that we're expecting a revisit now back in May. They're being very supportive of us and providing a education and training package at a ward-based level, and we want to roll that out collectively and in partnership with them before they return to do the visit. Those are the key areas that I'd just like to cover, and I'll just hand over to Christine for the other key metrics.
Thank you, Jackie. A couple of things I'd like to highlight, really, that we have continued to sustain an improvement in getting patients with fractured neck of femur to theatres, although a little lower than previous months. This has been mainly related in December to theatre capacity, as well as some patients being initially unfit for theatre. We've also improved our antimicrobial stewardship measures, and that is now a sustained improvement, with 95% of patients receiving appropriate antibiotics, and the target of them being reviewed within 72 hours also achieved, and that is related to our action plan in relation to C. diff infection. In terms of sepsis, more than 90% of patients have had blood cultures within an hour of presentation, and we have sustained good performance in terms of length of stay and mortality from sepsis. However, we continue to struggle to get antibiotics into the patient within an hour, and a lot of that is related to the pressures that you're well aware of within the emergency department. I think that was the main things that I wanted to highlight from a quality perspective, but very happy to take questions on the rest of the report.
Thank you, Christine. Oh, Tony's got what's coming.
Yeah, thank you, Chair. Christine, it's a question about the fractured neck of femur paragraph. Obviously, I don't have the background on it, being relatively new to the board, but taken as read, it looks a fairly challenging situation. And what I couldn't see from that paragraph was whether there was a solution to the problem in the short or medium or indeed long term, what any timescale might attach to it, because it looked to me like there's quite a big gap to be closed to get us into a good position. Thank you.
Yeah, I mean, that although the performance is not where we want it to be, that actually represents quite an improved position, and the last 3 months have been the best 3 months out of the last 12. We had a challenge with the fractured neck of femur pathway, which is really a red flag for challenges with the whole of the orthopaedic trauma service after the move to Worcester, and it's taken a bit of time to get it back on its feet. So back in November we had an away day with the trauma and orthopaedic surgeons, anaesthetists, nursing staff, trauma coordinators, and everyone involved with the pathway to look to map out the pathway and look at where the delays and challenges were. that's resulted in production of a very comprehensive improvement plan, looking at all points in the patient pathway, and the team are working on that. And I think that is the reason for the improvements that we've seen in November, December, and through into January and February as well. We are due to meet with the T&O team to look at the details of that plan and where we are with it. But it's quite a big piece of work that we've been doing.
Thank you, Sue. Sorry, Christine. Sue.
Yes, thanks, Chair. Christine, I'd just like to affirm what you've just said, really, because this is a weighty, complex problem, and your Wayday and the rest of the team in the orthopaedic team are clearly responding to something that's been flagged up, and it's not a quick fix. But the trajectory, I was worried about this 12 months ago, but the trajectory is obviously going the right way, and the goodwill is clearly there when you talk to people.
Thank you.
Thanks, Sue. I had one question. I think Paul alluded to it in his part of the report, but I know from data that I've seen that actually we've been making a lot of progress in terms of getting people back to home when they've been inpatient, as quickly as possible, so they can get back to their loved ones. And I know we've made a lot of progress with that, particularly in terms of simple discharges, people going home as opposed to requiring any kind of support. I know at last month there was, I think we had a bit of a discussion about whether we were seeing any kind of repercussions from that, be it in terms of readmissions or mortality, or I think, carers struggling or so on. I don't know whether there's any update from the team about, do we have assurance that it's working well? Do we still have some concerns? What's the view? Paul?
So from just reviewing the data, the hard data, we're not seeing any, if we look at the simple discharges, we're not seeing any increase in readmission rate. And actually, we've monitored for the last 6 weeks, the last 6 weeks here compared to the same week a year ago, and at both the Alex and Worcester, the length of stay for those patients who go home alone or simple discharges has hardly moved. We've monitored 6 weeks week on week now compared to the same 6 weeks week on week in 2022. What we have seen, and I think Matthew did refer to it in his chief exec's report, that length of stay has increased over the last 12 months. What the data is telling us is that about the increase in length of stay is actually predominantly related to those patients who are going home on a pathway discharge. What I haven't done yet, and I don't know if Christine's got anything, I haven't looked at readmission rates for pathway discharges, but in the report that we had done by OCT that Lisa Levy on behalf of the system via the ICS that did highlight an issue of readmissions on pathway discharges. So I'll pick that up, and if it's helpful for kind of non-exec colleagues reading, it is possible Rebecca might be able to put the OCT report in the reading room, because I think it is an interesting and helpful report that also makes a number of recommendations that we have accepted, as has colleagues in the County Council and the Health and Care Trust, that if effectively implemented would have a positive effect. But certainly on the simple discharges, we haven't seen any change in the readmission rate, nor have we seen a change in the length of stay. We have seen that increase in length of stay on pathway discharges and that report did refer to level of readmissions.
Thank you, Paul. Yes, I think from the board's perspective, I think we know we want to get home, patients back to home, or where they call home, as quickly as we can, to get them back to their loved ones. But it's just about us getting assurance that we're doing that in a way that is safe and it is not causing issues down the line. So thank you for that. I don't see any other hands raised, so I wonder if we could move to people and culture. So is that Tina?
Yeah, just headlines. So,
thank you.
Same narrative as previously reported, in that we're on track to meet our workforce plans regards to the number of staff in post by the end of March. Unfortunately, we're not seeing the benefit of the reduction in agency and bank as a result of that, because of higher than predicted levels of staff turnover and sickness absence, but also the requirement to continue opening surge areas for our urgent emergency care. And so the focus for going into the new financial year is going to be on recruitment and retention to address the bank and agency human staffing costs issue. Not in the report today, but just for board awareness, the staff survey results are being published nationally today. I have circulated them to board members, and we will be having a report through to at the board meeting in April.
Thank you, Tina. Any questions or comments for Tina? I don't see any hands, so thank you, Tina. So can we move on to finance? Neil, please.
Thank you, Chair. So we've reported a 0.4 million favourable variance in month 10, and that's leading to a 0.9 million adverse variance against the plan year to date. In terms of the large swings that you see in month 10, it's very much common to the previous months in respect of expenditure that has been funded. So it's around the pay award. It's around drugs and devices that have been passed through, in addition to additional investments around winter and to support the backlog of activity. In terms of our forecast, so we are still in line with our forecast. We have invested 1.4 million in the month from our balance sheet, and in addition, we reprofiled some of the capital programme, brokered some funds into next year, which I'll come on to, and that's reduced our depreciation forecast for the year. So we're in line with where we said we would be, still expecting to achieve the 19.9 million plan, albeit, as we had said previously, largely with some support from the balance sheet. In terms of our PEP, it's now projecting at month 10, 10.4, so just over 5 million shortfall against the plan, which is why we're having to invest from the balance sheet to supplement that. Capital is a challenge in respect of, you can see there, we've expenditure to date in month or up to month 10 of 24.6 million, so forecasting 26 million to be spent from month 11 and 12 in effect, 26.3 million. We're on track in respect of that, I am assured. They're largely around the large schemes, the UEC and the TIF2. We're meeting with the States team on a day-by-day basis just to make sure there's no swings in that respect. We had seen some movement in respect to the TIF2 forecast that's led to an underspend on our capital programme, about £800,000. And we've been working with the teams just to ensure that we can call schemes forward from next year's plan to ensure that we don't underspend against the capital programme. So I'm managing this on a day-by-day basis as we speak. Clearly we've only got a few weeks left now to the end of March, but we need to maximise against the capital resource limit or risk, some of that being taken away from us. So at this stage I'm still confident we've got a plan to manage that. In respect of cash balance remains high, and again, confident, meeting with the team on a regular basis, confident we'll have the right cash balance to meet our external financing limits at the end of the financial year. Happy to take any questions, Chair.
Thank you, Neil. Any questions? Tony?
Yeah, thanks, Neil. It's a question about the capital item you just mentioned, and it's the reference to the 4.5 million increase since month 9. I just wondered how we'd achieved that. That looks quite significant as a proportion of the total programme.
4.5 million of expenditure.
Yeah.
I mean, that'll be across a range of programmes, Tony. It's across the whole gambit of the programmes that are there. So that's the 4.9 million of expenditure since month 9. So what we spent in month 10, that's the 4.5 million of expenditure that's been incurred across all of our capital programmes.
Right. Okay. Thanks.
I mean, I can give you a breakdown, Tony, if you want. But it'll cover.
I was just interested if it was any single or group of very large projects, but you're saying it's across the board.
It's across the board, but it would largely be in our TIF2 and the UEC.
Okay.
Thank you. Simon.
Just an observation, just looking out my window here in a wintry Worcester. I hope the weather behaves itself for the next couple of weeks, because if anything can throw off construction projects, bad weather can.
Yes, invariably there's always a risk, and as I say, we're meeting on a day-by-day basis as we speak here. So these are all programmed in. The work is programmed. Therefore, the expenditure that sits behind it and the cash payments are all profiled in. So, as I say, we're meeting the team on a day-by-day basis, and we're keeping very close to this, because clearly we'll need some mitigation otherwise. And indeed, we have been working mitigations in the background around what else could we pull forward from next year if we had to. It may well lead to 1 or 2 vesting agreements at year end around purchased equipment that remains off-site. But I would be assured that if that is the case, they've got the reference numbers and they are owned by us and they have a proper vesting agreement in place. But that's as we sit here right now. We've got a plan.
Great. Thank you, Neil. If there are no other questions or comments on the IPR, I suggest that we move on. So thank you everyone for as I say, there's a lot in there that actually shows a positive direction of travel, progress, and you know, notwithstanding the fact that we absolutely have to keep focus on the things that haven't yet shifted or haven't yet moved. It's good to see that there is progress across several areas there. Right, moving on then to the committee assurance reports. I'm just trying to find it in my pack. If anyone happens to know and can tell me which committee is it first, is it F&P or is it QGC? I can't remember now.
F&P.
F&P, thank you. F&P, I know Richard is not here. Colin, I don't know if there's anything you wanted to draw to our attention or you wanted us to take it as read.
Happy to take it as read, Chair.
Oh, that was short and sweet. Sweet. Any comments on the F&P committee reports? No, I don't see anything. Okay then. Moving on to QGC. Julie's not here. Sue, would you like to bring anything to our attention?
Yeah, I mean, our colleagues have actually the two things that Julie wanted escalated were in relation to the elective care inpatient support team. That visit was actually back in November, and there were 10 key recommendations, which we have an action plan split into informatics, elective and cancer, which address that. And I think what Paul was alluding to, that there's already, I think there's green shoots of progress seen in that regard. And the second thing she wanted you to have awareness of is the IPC visit, which Jackie referenced, where C. diff remains a central focus. There's extensive discussion at QGC in relation to us taking a more holistic look at why we are not an outlier within our region, but our part of the world is an outlier nationally, and we don't entirely understand why that is. But the action plan's in place. I think it's got something like 33 fields on it, but focusing on things like challenging and appropriate use of gloves, just not wearing a pair of gloves for the shift to keep your hands clean, and that sort of thing. But I mean, Jackie and her team were all over it, and Jude just wanted you to have awareness of it. I think we've covered it largely.
Right, thank you for that, Sue. Any questions or comments on the QGC reports? No, I don't see anything. So thank you both. So moving on, amendment to scheme of delegation. Who is that? Neil? Yes, it's Neil, isn't it?
Yeah, me, Chair. Thank you very much. Yes, so the board will be aware that through our forward improvement programme, one of the first value streams that we've looked at is recruitment, and the first rapid improvement workshop, rapid process improvement workshop, was around improving our request to recruit process. And we previously brought back, if you recall, a first stage or a first route in that respect. So if it was within budget, if there was a person within post in the last 6 months, then fine. It would be handed over that the divisions could actually process those requests to recruit themselves. There was a second request, which was basically, if it's in the budget, and if there are, for example, 2 posts that make up a band 3 and a band 4 making a band 6 or a band 7, whatever, could we actually put that into the process as well? I think I'd raised some concerns at the time because of our vacancy factor process, that we needed to review that further. I've since been out to the GEMB. I've since had a look at the app. So we have developed an app. Division, specialist medicine division, who is leading this process, have worked with Vicky's team to develop an app. Had a look at the app this last week, and it's fantastic once it's been developed. I think one of the concerns that I had at the time was that actually we would need an approval process through finance and through workforce in order to get these signed off and be assured that the money was in budget. And so what this is outlining is a further amendment to the scheme of delegation to compensate for that, to make those changes. So the changes 12.A that you'll see in the report are those that currently exist. 12.B is this further proposal that we want to put in place. So where it's within funded establishment and it's fully funded for the duration required, and the department or cost centre is in budget overall for the financial year, and the assurance process that would be in place to confirm that is the case with this app that is being trialled through specialist medicine at the moment. So we will review at the end of the trial period before we roll out further to the organisation. So the app has a process within it where the person filling out the request to recruit form on the app needs to tick and certify the boxes that I've discussed this with my divisional business partner in finance and within HR, and that they confirm that they're within budget and within establishment, and then they certify that. A report then goes back to the division management board on a monthly basis to confirm those, and indeed there's a report then that will come out to the HR business partner and the finance business advisor, that they can retrospectively confirm that those decisions that were made were in line with expectation. So there'll be a secondary check that come out the back of it, if you will. So as I say, we need to change the SFIs in order to trial this through specialty medicine. Once we've been through the trial, we can confirm whether it's acting as we had intended, make any changes associated with that as necessary, and then roll it out to the organisation wider. So this is asking for that so that we can put this trial for that secondary process in place, please.
Thank you, Neil. I know Matthew. There's a couple of hands, but I wonder if I could just ask one question, because it might be on several people's minds, I guess. This sounds sensible. It sounds like you've put in controls and safeguards around it. I guess the piece that I am missing is that how do we make sure that we use the opportunity of somebody leaving to actually consider productivity, efficiency, different ways of working? Because often in reality, it's when somebody leaves that actually that that thought process happens. And given we know that that's something that we want to do and we need to do, everything you've done sounds sensible. And with controls in, but it seems to imply that it's going to perpetuate status quo. And I'm wondering, how do we insert that ability to just check that there aren't smarter ways of doing things?
I guess there's a number of measures there, Chair. Firstly, I from the perspective of the divisions have a PEP to deliver on an annual basis, and they're well aware of the expectation that's placed upon them in the PEP. The secondary component to that is that anything that goes through here still needs to be signed off at divisional management board level. So that process that it would go through, tick verification, this makes sense, and indeed it's in line with our expectations, and therefore if there's any further opportunity. The HR business partners involved from an establishment perspective, as is the business advisor from a financial perspective. So it still goes through levels of scrutiny for that challenge to take place. So I think from that perspective, there is ample opportunity to challenge if this is. But I think this is, from my perspective, this is what this is trying to do, but shorten the timeline in order to achieve that fundamentally. I think that's part of the challenge has been, I want to do a skill mix review. The skill mix review will take months to get through. This is actually, if you've got a band 3 and a band 4 and you can make a band 6 and make some savings out of it, put that through this process, get a certification from your business advisor, your business partner, get it through divisional management board. It could be out to advert within days of that. That's the whole purpose of this, the intended removal of waste around all of this.
Right, thank you, Neil. Matthew.
Yeah, thanks, Chair, and thanks, Neil, for that summary. I think the key additional point to make, and certainly this came up at the conference on Tuesday from the staff that were there, is that sense of will these changes that have been developed by the staff doing the work be rolled out, and will barriers to being rolled out be removed? And I think there's a desire on the executive team to remove those barriers. There's a desire on the frontline staff to see that happening in order to build confidence and trust in both the leadership but also the methodology. And I think what Neil's described is going out and seeing for himself, getting that assurance, and that model of leadership is something that we want to engender right across the organisation. So fully support the way in which Neil's gone about it and the proposal here today.
Thank you, Matthew. Tony.
Yeah, thanks, Chair. My point's probably just a bit pedantic, but it's about words and meaning. I'm looking at the 5 bullet point criteria on page 120 of the pack. Page 2 of the report. You've got 5 criteria there for being signed off, and it's the bottom one which says department cost centre is within budget overall for the financial year, and it's the use of the word budget. I'm wondering whether is that the word we really intend to use, or do we mean establishment budget? Because I could foresee a situation where a departmental cost centre is perhaps not within budget for things that have got nothing to do with their staffing. So it's just a clarification for me about whether we're just talking about the establishment budget or the budget. It uses the word overall. Thanks.
And that's a very helpful point, Tony, because that's the nub of one of the challenges that I had here. Invariably, because we have a vacancy factor, we can't appoint to all of the established posts in our budgets because we carry vacancies on an annual basis, and therefore, from a budget perspective, there's a deduction on an annual basis. It is budget rather than establishment, so we can't over appoint to our establishment, to our budget, basically, using the establishment. Otherwise, we would incur a huge deficit. So it is a cost budget, yes.
Thank you very much. Right, I mean and thank you for answering our questions. We are requested for approval. It's got level 6 assurance. Are we happy to approve this change to the scheme of delegation? I'm seeing lots of thumbs up. Neil, thank you very much. That's approved. Right, moving on to safe staffing. I'm guessing that's nursing and midwifery So is that Jackie going first?
It is. Thank you very much, Chair. So the report that I will take as read is for the month of January, but you will note it's December data with the reporting timeframes. As we've said previously, both of these timeframes were quite a challenging period of time for us. Staffing, I can report, was maintained safely. And that is through our safe care that we use to do that reporting from a ward-based perspective of number of nurses that we have available for the patient needs and demands at that moment in time. We have to make sure that we have covered patient need safely, required the use of bank and agency staffing, and that is predominantly at short notice due to last-minute sickness. The report does also cover our vacancy factors, which is a contributing factor, obviously, to safe staffing on the wards. And our registered nurse, as you will see, trust-wide, is sitting at 176. That remains the same from our last reporting period, with roughly give or take, which it does go up and down, obviously, in months. And that's very similar benchmarking across other trusts. We are, however, an outlier with regards to our healthcare support workers. As I've mentioned before, we currently have a vacancy factor of 12.3%, and this is obviously a key work stream that we have been on for a number of months. The other area I'd just like to raise awareness is across our whole areas. We do have a hotspot with radiology, and again there's targeted recruitment that is in place with regards to that, but from a vacancy factor, from a healthcare from that perspective, it is a challenge, and therefore they are also using bank and agency in which to cover. The well-being piece of work has obviously been key for us for these months, and we do still have staff that are reporting real challenges, I think, particularly with the cost of living, and that's more with our healthcare workers, and we've been working with HR, looking at packages of care to support staff, obviously thinking about from a confidential point of view, this is a very hard and difficult area, but we are been seeing some of that coming through. The biggest area for us in this area is obviously we've been subject to a number of strikes, as has been reported previously, and I'm not going to go over some of that, but more in how this is actually having an impact for our staff across all areas, both in terms of supporting our members who wish to take strike action, but also the volume of work that this does involve at a ward-based level. And so actually thinking about team working, team dynamics has been really important for our divisions, and they have had a focus on that. Happy to take questions.
Thank you, Jackie. Any questions, comments for Jackie? Nope. Thank you very much. Great to see level 6. So thank you. Justine.
Good morning. So this is the midwifery safe staffing report for January with an assurance level of 6. That's an increased assurance level finally, and so it's a bit of a good news story. We've reduced our vacancies and our sickness, our turnover and our red flag reporting, so that supports the recommendation of the increased assurance level. That also has meant that we've reduced the times that we need to escalate some of our other staff groups, which is always popular. Our fill rates and the times we met acuity are always up, so it is generally positive from a midwifery point of view. As Jackie said, we have the same or similar problems within our maternity support worker group, and there'll be a lot of work going on, and there is already some work started to improve that position, and I'll report on that going forward. And I'll pause there and take any questions.
Thank you, Justine. And yes, I internally whooped when I saw the level 6 there, so yes, well done.
Thank you very much.
And any questions or comments for Justine? I don't see any. Thank you both. Good to see level 6 assurance for both staffing, nursing and midwifery. If there's no questions, we'll take those for assurance. Thank you very much. Right, moving on then to Board Assurance Framework. I think that's you, Rebecca.
Yes, thank you, Chair. Also pleased to present an increased level of assurance here. Industrial action, whilst has given us many challenges, it's given us good evidence to be able to show that the Board Assurance Framework has been responsive and effective in terms of managing that risk. The risks within the report I'll take as read. I don't intend to talk through them, but it's we can clearly evidence that the committee structures are well engaged and that we've got good embedding of the BAF across the organisation. Some of the levels of assurance, there's been a number of changes. Again, the main significance is an increase in the industrial action risk with alongside a decrease in the level of assurance, having previously yo-yoed when our previous experience of the strike was actually that our management response was effective, the risk had dropped, but clearly the environment in which we're operating is changing in that respect. There's one amendment on the summary which is within the main which is already included in the main document on engagement of staff. That was a level 12, but unfortunately I missed it in the industrial action risk yo-yoing of the score, so apologies for that. Overall though, like I say, we have we've got mitigating actions in place against all risks. We're clear as to the assurance that we have against them, and just listening to the discussions that we've had today, the assurance framework is reflective of the risks that the organisation faces, and it's clear that the risks we face then therefore lead the discussions that we're having at board. I'll pause at that point for any questions. Thank you.
Thank you, Rebecca. Any questions or comments for Rebecca? No. Again, I think there's been some real progress here. I think it's good to see an increase in the level of assurance, but I think this is very clear. I think it, and the thing I think I'm particularly keen on is, as you highlighted, Rebecca, the fact that to some extent it's actually been proof, if any were needed, that this is a living document, that we are absolutely working with it and assessing risks and in real time or close to real time, and I think that's very encouraging. Christine.
Yeah, it's in relation to the dynamic nature of the risk due to industrial action, because of course the industrial action we're dealing with is changing all the time, and the upcoming one about junior doctors is to my mind one of the most difficult to mitigate, as we're very reliant on the goodwill of other staff doing extra contractual work, extra contractual activities in order to mitigate that risk. So that is the focus of quite a lot of effort that's going on at the moment to try and manage that. But that is going to be a big challenge for us.
Yeah, thanks, Christine, and completely agree. I mean, I have to say none of the strikes have been easy, but it's the one I think I'm certainly most that I think could potentially cause us the most challenges. I agree. Any other questions, comments on the BAF? Level 6 assurance, are we happy to take it at that? Thank you. Any other business? We had none at the beginning. Obviously there are documents in the reading room that gives more detail on some of this stuff. Our next meeting of the board in public is going to be our experiment that Richard alluded to. So we are still going to be hopefully streaming on YouTube, but it will actually be a face-to-face meeting on Thursday the 13th of April, I think is the date that's in my head. And so hopefully those of us that watch us on YouTube will continue to have your excitement, but you may just get a slightly different view because the rest of us won't be on Teams anyway. For board members, I think we're meeting back in 1 hour to take some items in private. For anyone else, thank you very much for joining us today, and we'll see you soon. Thank you very much. Bye-bye.